patient has recurrences, you will give the normal prophylactic dose of 400 milligram BD for 1 year. Therapeutic trial for herpes simplex stromal keratitis not on steroids, and stromal keratitis on steroids with iridocyclitis. In practical terms, if the patient has herpetic disease, stromal keratitis without epithelial involvement, you can use topical steroids. You do not have to give acyclovir cover, but if you have a strong suspicion of associated keratouveitis, you can give oral acyclovir. Topical acyclovir is not that useful. The HEADS-2 trial, herpes simplex viral epithelial keratitis trial, where they evaluated the beneficial effect of oral acyclovir given during treatment of an acute attack in preventing the occurrence of later blinding complications. And as I mentioned earlier, basically that it is to be used only for recurrent disease and given for a year. Surgical treatment, as I said, can be done for necrotizing stromal keratitis, a tectonic therapeutic keratoplasty, or a patch graft, which can be quite rewarding. Thank you.
Thank you, ma'am, for the amazing insight in corneal infections. We will not be breaking for tea because we are very much behind time. Anybody who is interested, I think all of you have already had coffee. So if we move along, we'll be right on time. We are making a couple of observations. There are some postgraduates who are using their cameras to take pictures of the slides. That is not ethical. We would like to request you to be attentive and listen to all the slides. Please do not take pictures unless you have asked the presenter who is presenting, because this is their property and you cannot take pictures of it. I would now like to request the next speaker, who is Dr. Rashmin Gandhi. He is from Center for Sight, Hyderabad. He has done his MBBS from PS Medical College, Gujarat. He has done his post-graduation from Shankar Nethralaya, Chennai. And he did his fellowship from Johns Hopkins University in the United States. At present, he is a consultant at the Center for Sight, and he is the Managing Director of Beyond Eye Care. A patient with ocular motility problem, what next? Dr. Rashmi.
Thank you, Satyajit. I would like to thank the AIOC for giving this opportunity. So, patient with ocular motility would always pose some sort of problem in the exam, theory exam, the clinical exam, or in your clinics. So this is going to be an interactive session on some of the patients that we do encounter frequently in our day-to-day lives, and how do you approach some of these patients. That's the basic parameter of this talk. So let's start with this first patient, a 36-year-old male who comes to you with a complaint of double vision for the last 3 weeks. The first question I would like to ask the postgraduates is that if somebody complains of double vision, what's the first question in history that you ask the person? Sorry?
The direction in which double vision is.
Okay, the answer was direction in which the double vision is more. Okay. Anything else?
Whether it's actually double vision or.
Okay, so the other answer is you would like to confirm whether it's actually a double vision. What else it can be? Diabetes and hypertension would come a little later.
Uniocular or binocular?
Fantastic. The first question you ask that patient is that is this double vision monocular or binocular? That's what probably you also meant. Why would you like to ask that? How does it help? Brilliant. There are different causes for unocular and binocular. What are they? So in simple words, monocular double vision which persists despite patient closes one of the eyes, comes from the eye. So the causes can be astigmatism, corneal opacity, corneal edema, subluxation of lens, and whatnot. Alright? So diplopia which persists despite one eye is being closed comes from the eye. Diplopia which goes away when either of the eye is closed is generally neurological in origin. So that's the first question you ask. The other question would be in which direction the double vision is more Does it fluctuate during the day? Why is that important? Myasthenia. Double vision, which is more in the evening or after activity, generally is indicative of diseases like myasthenia. So that's the first question you ask yourself. Now let's look at the ocular motility examination of this patient. This is how it looked like. So this is patient looking straight, patient looking to the right, and patient is now looking to the left. Patient looking up, patient looking down. The other gazes are blacked out. What's your observation? Sorry? Basically what you observed is that the right eye was not abducting. Is that right? Okay. Let's move on. What would you do next? Right eye is not abducting is what you observed in this 36-year-old male who came to you with a sudden onset of double vision. What is the immediate next step? Just think that this is the patient that you are examining in your practical exam. What would you do next? Obviously, diabetes, blood pressure, all that would come later. Now, patient is sitting in front of you in your exam. So, the first thing that you need to do if you see a patient with an abduction deficit, the commonest cause of an abduction deficit would be 6-nerve palsy or lateral rectus palsy. So, the first thing that you do is determine whether this 6-nerve palsy is isolated or are there any other cranial nerves involved. So, that's the first step. So what are the cranial nerves you are specifically interested in? Third nerve, you saw clearly there is no involvement of third nerve. When you check ocular motility, you would rule out by and large involvement of third and fourth nerve. Okay? Seventh nerve, yes, and eighth nerve and fifth nerve. I heard some trigeminal nerve. So specific nerves that you are interested in apart from other oculomotor nerves are 5th, 7th and 8th. So the immediate next step when you see a patient with 6-nerve palsy is to check for corneal sensation. Check for corneal sensation, make sure that corneal sensation is intact. 7th nerve, you do the routine test, ask the patient to squeeze the eyes tightly, ask the patient to raise the eyebrows, puff his cheeks, and the 8th nerve will be hearing. Okay, so the first question you ask yourself is this a 6-nerve palsy? By and large, all abduction deficit, the first differential would be 6-nerve palsy. Second question you ask yourself is this an isolated 6-nerve palsy or are there other cranial nerves involved? What next? Let's see if you found that the other cranial nerves were normal. What would be the immediate next step? So, first question, is this an isolated 6-nerve? Second question now you need to find out is why the patient has got 6-nerve palsy. So now in a 36-year-old male, what would be the immediate step? Sorry? Any history of trauma, yes, ruled out. Remember, so now immediate next step is to find out the etiology. In a younger patient, any patient who is less than 40, you assume that the 6-nerve palsy is because of compression unless proved otherwise. So in other words, patient less than 40, irrespective of what the other history may be, you need to advise neuroimaging. Right? Because you assume that the patient has 6-nerve palsy which has developed because of compression somewhere along the course of 6-nerve. The other important issue, not in a video that I showed, but in an ocular motility which is a little funny, is you ask yourself, is this ocular motility problem coming from the muscle? Is it coming from neuromuscular junction? Myasthenia is the example. Is it coming from any of the cranial nerves which move the eyes? Is it coming from the brainstem? Because it's the brainstem where all the nuclei are located. Nuclei of 3rd, 4th and 6th are located. Or is it coming from the supranuclear centers, the centers which control these nuclei of cranial nerves? And then isolated 6-nerve, we'll discuss about neuroimaging and role of other tests. So with this framework, let's look at the 64-year-old male who also complained of double vision for 1 week. What's the immediate first question you ask yourself? If the patient complains of double vision? Is this monocular or binocular? Very good. And now let's look at his ocular. So this is patient looking straight. Video courtesy Shankar Mitralaya. and this is patient looking to the left, and now this is patient looking to the right. Right. Observation? Again, left abduction deficit, more likely to be left six-nerve palsy. But if I want to ask you about this particular framework, do you think this patient has a problem with the supranuclear centers? Possible? Yes or no? There are quite a few heads which are nodding horizontally that side. Why would you say that this is not a supranuclear center problem? Shout out. Yes, you can shout out. Sorry?
Supranuclear regions are symmetrically involving in that.
Yes, supranuclear centers generally would cause gaze palsy. It will involve both the eyes, while here the other eye ocular motility was normal. Very good. What about the brainstem? Can it be a brainstem problem? Can it be a problem with the nuclei of the sixth nerve? Yes, possible. We'll talk about it. Now, possible. Can it be a neuromuscular junction problem? Can it be myasthenia? Remember, myasthenia is a great mimic. Any ocular motility problem, you would assume it's myasthenia if it's not fitting into any other pattern. Except one ocular motility problem, you will say that whatever it may be, this is not myasthenia. What is that ocular motility problem? Sorry? Exactly. If ocular motility with pupillary involvement, it's not myasthenia. It can be anything else, it's not myasthenia, right? So in this framework, we know that this is not supranuclear centers, this is not brainstem. It can be either muscle, neuromuscular junction, or the nerve. So in a 64-year-old male, patient that you saw, if the patient is hypertensive and diabetic, and if it's an isolated six-nerve palsy, you are justified in just observing that patient without really doing any other test, except for the test for its vasculopathic risk factors. Now, when I say no other test, I generally mean neuroimaging. So in this patient, even if you don't do neuroimaging, that's fine. But if you have not done neuroimaging, then it's important that you call the patient every week and examine the patient, check ocular motility, do corneal sensation, check for seventh nerve, check for eighth nerve, check for cerebellar function every week. Because if there is a slow lesion anywhere in the course of the sixth nerve, which is slowly expanding, then the other nerves can get involved later in the course of the disease. Alright. Let's move on to one more case. This is a young female who had a history of trauma. She is looking to the right and looking to the left. Looking to the right, looking to the left. Observation. What did you find? Again, a left abduction limitation. Anything else did you observe? Narrowing of pulpal fissure, or maybe a little bit of phenophthalus. The eye looked a little bit inside, and also patient had a trauma. What is your first thought now? Sorry?
Entrapment of the muscle.
Yes, this is likely to be a restrictive pathology in view of history of trauma and in view of a narrow pulmonary fissure on the affected side. This is likely to be an entrapment of which muscle? Medial rectus. So if I say that yes, this patient would need neuroimaging, what would be the modality of choice? CT scan of hip joint. CT scan of brain and orbit. Absolutely. Why do you need to have both brain and orbit? I mean, if you advise CT scan of brain, you would be able to see orbit in it. Why would you specifically say CT scan of brain and orbit? Absolutely. Because of the angulation of the orbit and the brain is different. So the way you see orbit is quite different if you just look at the brain plates versus an orbital plates. And when you advise for a CT scan of orbit, you would get a thin section of the orbit, so you'll have a more information about the orbit. So remember, if you are advising a CT scan in this case, you need to mention brain and orbit both. So just to summarize, if you see a patient with abduction deficit, apart from sixth nerve palsy, these are the other features that these are the other conditions that you keep in mind. It could be restrictive pathology in an appropriate setting. Restrictive pathology can be because of entrapment of muscle, as we saw in that patient. Rarely thyroid ophthalmopathy also can cause fibrosis of medial rectus, hence having a patient having an abduction deficit. Myasthenia is a great mimic. Duane syndrome can also produce abduction deficit. So always look at eyelid very carefully if you see a patient with abduction deficit. Let's look at this patient now. This is a young male. He has an obvious esotropy on the left side with congestion. Look at the left upper eyelid. There is a gold wedge implant. You can see a little prominence of the left upper eyelid. That's because of gold wedge implant. You can see that little smudge and a gold wedge implant. So patient looking to the right, patient looking to the left, up, down. Your thoughts. What do you think is happening here? A young patient, abduction deficit, one more example. Some sort of nystagmus in the right eye, I don't know whether you noticed it, and a gold wedge implant on the left upper eyelid. A gold wedge implant was done because patient had leg ophthalmos, which is now corrected. So 6th nerve, leg ophthalmos is coming from 7th nerve. Where would be the lesion? So the next immediate step, now this is not an isolated 6th nerve palsy. We have moved out of this isolated 6th nerve to multiple cranial nerves. So now there is a 6th nerve and a 7th nerve. Where would you place a lesion? So somebody is saying nuclear lesion. Why would you say? Because the 6th nerve nucleus is in the pons and the 7th nerve makes a loop around the 6th nerve nucleus, forming a facial colliculus. What did you see in this video, or maybe in the next video, which will tell you that next video also is a similar patient, which will tell you that this is not a nuclear lesion or pontine lesion. Look at it very carefully. There is one feature I want you to point out, which tells you that this is not pontine lesion. This patient also has a left abduction deficit. Already a little heightened tear film of the left side. And once you look at the eyelid, you know what else is happening. Patient looking to down and right. All other ocular motility is fine. And this is what is happening when the patient closes the eye. Right. So 6th nerve, 7th nerve, again, I don't know whether you noticed, there was a nystagmus of the right side. And you said that a similar patient, the previous patient, you said that patient has a pontine lesion. Now I'm telling you, no, this is not a lesion in the pons, this is not a nuclear lesion. How would I justify? What is one feature which is missing? Let me show you next video. Now, this video is actually a patient with pontine lesion. So this is a patient looking to the left. Again, if you see the right upper eyelid, gold wedge implant has been done. Patient looking to the left, and now patient is looking to the right. Now patient is looking to the right. What was the difference between this patient and the previous patient? Remember, the point I want to make here is that this patient also had the right 7th nerve palsy because gold wedge implant has been done. So one important feature here is even the left eye, contralateral eye, is not adducting. What patient has actually is a gaze palsy. So a nucleus of the 6th nerve, which is located in the pons, if there is a nuclear lesion, generally you have two features. One, involvement of the 7th nerve because it is very close to the 6th nerve in the pons, and two, 6th nerve nucleus because it is very close to a tract called PPRF. What's the full form? Parapontine reticular formation. 6th nerve with PPRF acts as a gaze center. I'm trying to ask you a simple question because we didn't give you a tea break. So I want to make sure you are all awake. So 6th nerve with PPRF acts as a gaze center. So this patient had a nuclear lesion. Because 6th nerve nucleus acts as a gaze center, patient could not see to the right. That means right abduction limitation, left adduction limitation. Is that clear? So then where would be the lesion of the previous patient? This patient, where would you place the lesion then? 6th nerve and 7th nerve. Remember there is a nystagmus here. Wherever there is a nystagmus, and if you are asked to localize the location of nystagmus, and if you say cerebellum, 80% of the time you will be right. So now 6th nerve, 7th nerve, cerebellum. So this is a feature. This is the patient who had a lesion in CP angle, cerebellopontine angle. So 6th nerve, if it's a lesion which is somewhere in the center, if it's in pons, you'll have a gaze palsy with 7th nerve. If it's in CP angle, you'll have nystagmus, gaze 6th nerve palsy, and the 7th nerve. This is the anatomy that you all know. Look at this young man who is looking straight at you. And now we'll check the ocular motility. Look at his left eye very carefully. So now this is patient looking to the left. What did you see? Abduction limitation of the left eye. Now patient is looking to the right. What do you see now? The adduction also was limited. Now patient looking up. What do you think? Looking down. Looking up and looking down. Yes, what do you think? So abduction of the left side gone. So we assume that maybe it's 6th nerve. The adduction also of the left side was limited, and elevation of the left side was not complete. What do you think? Can it be myasthenia? Possible. Myasthenia can mimic anything except any ocular motility with pupillary involvement. So this can be myasthenia, yes. Can it be a muscle problem? When you say muscle problem, you think about myopathies. Myopathy is possible, but myopathy generally is bilateral, generally symmetrical, little later in the disease, would involve the eyelids. Right? Can it be a supranuclear problem? Yes or no? Can it be supranuclear problem? No. We said in the beginning, supranuclear problem would involve the other eye. Here the other eye was normal. So in other words, what this patient had was a 6th nerve and a partial 3rd nerve. Elevation, adduction and depression was limited. Ptosis is not very pronounced. So if I tell you that it's a 6th nerve with a partial 3rd nerve, where would you place the lesion? Which location would you have 6th nerve and 3rd nerve going together? Cavernous sinus, absolutely right. Can it be an orbital lesion? Even in orbit, all these nerves converge together. Can it be an orbital lesion? What information would differentiate between this being an orbital lesion versus a cavernous sinus lesion?
Superior division involvement.
Sorry?
One division involvement of oculomotor nerve. Before
that? Absolutely right. That would also differentiate between a superior orbital fissure and cavernous sinus. But the orbital and cavernous sinus, the important issue is involvement of the optic nerve. In an orbital lesion which involves the other cranial nerves, you would find that the patient's optic nerve is involved, vision would be poor, patient would have ROPD. Versus in cavernous sinus, optic nerve is nowhere near the cavernous sinus, so the vision would be alright and the optic nerve function test would be preserved. So this patient actually, the vision was fine and the lesion localized to cavernous sinus. So in other words, this is the anatomy of cavernous sinus, which I will skip for the amount of time. So we finished with the abduction deficit and 6th nerve. We said that isolated 6th nerve in a young patient, below 40, you do neuroimaging. Isolated 6th nerve, above 50, with a clear-cut vasculopathic risk factors, you can observe, but see the patient every week. And when you observe the patient, you always check the corneal sensation, look for 7th nerve, look for 8th nerve, look for cerebellar function. Any other cranial nerve involvement? Commonest nerve with 6th nerve would be 7th nerve. There are 2 locations where you will have 6th and 7th nerve both, CP angle and brainstem. In brainstem, if it's 6th and 7th nerve, you will have a gaze palsy. In a CP angle, if you have a 6th and 7th nerve, you will have nystagmus because of cerebellar involvement. Or at least the other eye adduction to normal. Clear? Let's move on. So, this is a 64-year-old male. This is how the eye appears when he looks straight. There was a complete ptosis. Now you lift the ptosis and you check for ocular motility. Patient looks to the left. Patient looks to the right. Patient looks up. And patient looks down. Right. Observation. Sorry? Third no palsy or which side? Right third no palsy. What is the immediate information that you would like to ask? Involvement of pupil. Why is that important? Yes, traditionally what is described as a medical cause and a surgical cause of third nerve, or more appropriate is a compressive lesion of the third nerve is more likely to involve pupil early in the course of disease. A compressive lesion of the third nerve. Commonest compressive lesion of the third nerve is, what is the commonest? Aneurysm of the gluteal artery. Posterior communicating artery. That's absolutely right. Let's be complete here. So, aneurysm of posterior communicating artery is the commonest compressive lesion of the third nerve. It can burst, can give rise to subarachnoid hemorrhage, and the mortality rate is 2%. And that's the reason why pupillary involving third nerve palsy is a medical emergency. The patient comes to you. If the patient's neuroimaging is not done, the first immediate step is to get the neuroimaging done, and neuroimaging of choice would be MRI hip joint and MRI brain and orbit with MR angiography or CT angiography. Alright, because you are now suspecting a compressive lesion of the third nerve, and as I said, commonest compressive lesion of the third nerve is aneurysm of posterior communicating artery, and that's what you want to rule out. Please always remember, third nerve involving a pupil is a medical emergency. Right? Okay, so the first step you would like to know in a third nerve palsy is pupil involved? The second question you ask yourself, if you see a patient is the fourth nerve functioning? Any idea as to how do you check for the function of the fourth nerve in a patient who has a third nerve palsy? Yes? You look for a vascular torsion? Yes? You ask the patient to close the eyes? Yeah. What do you do? Alright, let's show you. Since we don't have enough time, let me show you as to how do you do. So you lift the eyelid, obviously. You're absolutely right. You look at the conjunctival vessel and you look for torsion. So in other words, you ask the patient to look from up to down in an abducted position. And look at the, I don't know whether you're able to see it, but look at the conjunctival vessel very carefully. Patient looks from up to down in an abducted position. And you'll see a torsion. If you see that the conjunctival vessels, you'll find a little torsion there. I don't know whether you are able to appreciate it, but anyway, you need to believe me, so that's what you do. Abducted position, up to down. You will find a torsion of the vessel. If you see a torsion, fourth nerve is functioning. If you don't find a torsion, fourth nerve is not functioning. So that's the second question. Now, the patient that you saw, do you think a patient has a central control of eye movements, or patient having a problem with the brainstem? Supranuclear, we said that, remember, supranuclear centers would have a bilateral problem. This patient has a unilateral problem. Question is, can she have a nuclear problem with the third nerve? The answer is no, because if you remember, this is how the nucleus of the third nerve is organized, and a nucleus, especially you need to concentrate on LPS and superior rectus, and you will find that those nuclei have, by and large, effect on the other eye. LPS would have a bilateral ptosis if the nucleus is involved, and superior rectus would have a contralateral elevation deficit because it supplies a contralateral superior rectus as well. Now look at this patient. Third nerve palsy recovered. Patient came to you after 4 weeks. You didn't investigate initially because patient was diabetic. And when the patient came to you, she has a mild ptosis of the left eye. You are checking ocular motility, and this is what you found. Patient looking up. Patient now looking down. Look at the eyelid carefully. Patient looks down. What did you see? Actually now it's frozen at the appropriate moment. What did you see when the patient is looking down? What's happening with the eyelid? Is the ptosis increasing or decreasing when the patient is looking down? there is actually a lid lag. If you see when the patient is looking down, the ptosis is decreasing and there is a lid lag. Where do we see a lid lag otherwise normally? Thyroid ophthalmology. What is it called? Warren Graffit sign. This is a pseudo Warren Graffit sign. Right? A lid lag seen when the third nerve is recovered, generally a sign of an aberrant regeneration of third nerve. So third point you note when you see a patient with third nerve. Third nerve palsy, first point pupil. Second point is the fourth nerve functioning. Third point, a little later in the disease, is there any aberrant regeneration of the third nerve palsy? Aberrant regeneration almost never seen in an ischemic third nerve palsy. So like this patient who was diagnosed as having ischemic third nerve palsy, if she develops aberrant regeneration a little later in the disease, you need to go ahead and do MRI and MRA, MRI brain and orbit, because as I said, if you see aberrant regeneration, it's a sign of a compressive or a traumatic lesion of the third nerve, never an ischemic lesion. Let's see what you have in store here. This is a young lady. Again, the video is not very clear, but also to show you a little aberrant regeneration. You will see the eyelid go up and down when you check ocular motility. We'll skip that. One more form of aberrant regeneration, generally seen in a pupil. This particular aberrant regeneration is called Zernick's sign. You see normal pupil on a slit lamp reacting briskly. The affected pupil, patient which had a third nerve in the other eye, you will find that the pupil is a little larger, and you will find a little bit of vermiform movement of the pupil. At the edge, you will see that it's moving a little bit, and that vermiform movement, when the patient would adduct that eye, you will find that vermiform movement would get a little more exaggerated. So this is also a form of aberrant regeneration. So remember, as I said, as you are looking at if you see that aberrant regeneration, again, that the vermiform movement is a little more pronounced when the patient adducts that eye. So three things to look for in a third nerve palsy: pupil, fourth nerve, aberrant regeneration. Let's look at very quickly 3-step tests for the fourth nerve. We covered the sixth nerve, we covered the fourth nerve. What is the step number 1 in a 3-step test? Marshall Park 3-step test. What is step number 1? Step number 1 is this. Which eye is higher? Or which eye is hypertropic when the patient is looking straight? Here, which eye is hypertropic? Which eye is hypertropic? Which eye is higher? Which eye is higher? Left eye. Brilliant. Now let's look at the step 2. But what is the step 2? What happens to this L over R when the patient looks to the right and to the left? So in which lateral gaze this left hypertropia is worse? That is step number 2. Tell me, what did you find? Patient looks to the right and patient looks to the left. So hypertropia worse when the patient looks to the right. Okay. What is the third step? It's also called Belchowski's head tilt test. So what you need to know now is what happens to this L over R when you tilt the head to either side. Your observation, please. Head tilt to the right and head tilt to the left. Which side it's worse? Which side? Left side. Brilliant. So this patient, this is the classical result of a 3-step test in a patient who has, what is the diagnosis? Left superior oblique palsy. Very good. So we covered 6th nerve, 3rd nerve, 4th nerve. Remember 4th nerve palsy, if you see a patient with 4th nerve palsy, the commonest 2 causes of a 4th nerve palsy are congenital and trauma. One thing you remember is that it is not the 6th nerve which has the longest course, it's the 4th nerve which has the longest intracranial course. Right? The 6th nerve becomes affected, or is 6th nerve palsy is a sign of false localizing sign of raised ICP, not because it has a long course, but the way it goes through from the pons to the eye, and that's the reason why you will find it as one of the false localizing sign. Let's look at this video. We have 13 more minutes, so we have some more videos. You can see, yeah. So patient looks to the left, looks to the right, looks to the left, looks straight, up and down. What did you find? Would like to see you again. Remember, very important is what happens when the patient looks to the right. Look at both the eyes when the patient is looking to the right. Patient looks to the left and looks to the right. What's happening here? I could hear some murmur, but not the answer. Yeah. Right abduction nystagmus, very good. And left limitation of adduction. Diagnosis? Left internuclear ophthalmoplegia. This is classical left internuclear ophthalmoplegia. And this is the circuit of the connection between the pons and the midbrain. And the internuclear ophthalmoplegia, the localization of lesion is which area? MLF, medial longitudinal fasciculus. So this is a cartoon which shows you sort of anatomical basis of internuclear ophthalmoplegia. This is a 6 now, and as I said, that is intact, which can abduct the muscle. This is the medial longitudinal fasciculus. If there is a lesion there, this I would not abduct, this I would abduct, but would have a nystagmus. This is how the patient would look like. What would you find here if the lesion is like this? Both medial longitudinal fasciculus are affected. So if both MLF, one INO, other MLF, other INO. So bilateral internuclear ophthalmoplegia, also known as Webino, wall-eyed bilateral internuclear ophthalmoplegia. Okay. What kind of ocular motility problem you find here? Sorry? 1.5 syndrome, right? Because what is affected is here EPRF and a medial longitudinal fasciculus here. Okay? So when you say 1.5 syndrome, what is the only movement which is preserved? Contralateral abduction. Okay. So this is a 70-year-old male who was diagnosed as having Parkinson's by a neurologist, and he was put on treatment. But this is how the ocular motility looked like. Patient trying to look to the right, patient trying to look to the left. When he's trying to look to the left, he's moving his head, and eyes are moving a little bit to the left. Very little, not much. Patient trying to look up, and patient trying to look down. So a 70-year-old male with a Parkinson's-like feature and virtually no ocular motility. So these are the kind of patients where, again, your algorithm of where the lesion can be would be useful. You go and ask yourself, can it be a muscle problem? Can it be a muscle problem? Yes. What kind of muscle problem? CPAO, basically a myopathy. So it can be CPAO, which is more seen in females, generally presents in a younger age group. Older age group, myopathy, you think of myotonic dystrophy or oculopharyngeal muscular dystrophy, which is not seen much in India. It's more seen in French Canadian ancestry. But remember, in a myopathy, you would have an effect of a process on LPS. So generally you will find ptosis, where here the eyelids are perfectly fine, isn't it? So myopathy, that's what differentiates myopathy from here. So can it be a neuromuscular junction problem? Can it be myasthenia? Possible. Myasthenia is a great mimic. It's possible, but again myasthenia would have some impact on LPS, but you need to keep myasthenia definitely in mind higher up in the differential. Can it be can it be a nerve problem? Can it be a nerve problem? If so, which nerve? it cannot be a nerve problem. If you are talking about nerve, means you are talking about bilateral sixth, bilateral partial third, that kind of lesion, patient will not be sitting in front of you and posing for your video. No. So can it be a brainstem problem? Can lesion be in a brainstem? Again the same thing. If you have a lesion which is so big that has affected bilateral sixth, third, everything, patient would not be sitting in front of you. Supranuclear centers? Yes, now effect is on both the eyes. So now a basic toss-up is, can it be supranuclear palsy? Can it be myasthenia? Can it be myopathy? One simple test which would differentiate between a myopathy and a supranuclear center is you do Doll's eye movement. Look for a passive eye movement. So you'll see here, gently move the eye, do a passive movement. Not very clear in this video, but the passive movement was better than when the patient was asked to move his eyes. So if the passive movements are present, it tells you that the lesion is in the supranuclear centers. If the passive movements are absent, it tells you that the lesion is at the muscle. These muscles are actual ground force. If the ground force is not functioning, everything gone. The supranuclear centers are not functioning, ground force can still do some movement. Alright? So do a passive movement in these kind of patients where there are no ocular motility, three possibilities. No ocular motility, three possibilities. Supranuclear center, myopathy, myasthenia. Myasthenia history would suggest, myopathy history and effect on the upper eyelid would suggest. Supranuclear centers, slower process, bilateral, passive movement would be present in supranuclear centers. So if I say this is a patient who has Parkinson-like features and a supranuclear problem, what's your diagnosis? Perfect. Progressive supranuclear palsy, also abbreviated as PSP, also known as Steele-Richardson syndrome. Quite often, frequently misdiagnosed or diagnosed as Parkinsonism. The reason why you need to differentiate between Parkinsonism and PSP is because mortality rate, immediate mortality rate at this stage, where all ocular movement is gone, within 5 years is quite high versus Parkinsonism. So PSP, the way it starts is, the down gaze gets affected first. So typical complaint is patient is not able to eat, not able to button his shirts, stuff like that. So down gaze gets affected first, then the up gaze, then the horizontal gaze last. It's a neurodegenerative disorder which affects generally the brainstem. So if you see a patient like this, you do MRI, you will find that degenerative process in the brainstem. We have some more gnan about PSP. We have 5 more minutes, so we'll show you some more videos. Here is a patient, old patient, again not able to move his eyes at all. But different feature here is patient also has ptosis. Patient also has ptosis, but is not able to move the eyes at all. So what are the clinical signs that you look for? Now here, because ptosis is there, myopathy and myasthenia would higher in the differential versus supranuclear. So what are the clinical features? If you say this is myasthenia, what are the clinical features that you look for? Sorry? Diurnal radiation is what patient would tell you. You would not sit in front of the patient the whole day. So it's a clinical test. Eyes test, before eyes test. Before tensilon test, generally given up because tensilon is not available. So the clinical test that you perform is 1, fatigability. Ask the patient to keep looking up at an object, right? And you measure the ptosis before the test and after the test, and you will find that ptosis would be worsened. Right? The second test would be ask the patient to tightly squeeze the eye and look for orbicularized ocular tone. This is a very sensitive test. Loss of orbicularized ocular tone is one of the early and sensitive signs of ocular myasthenia. And what sign, twitch sign that you look for? Cogan's lip twitch. How do you perform that? Ask the patient to look down for around 15 to 20 seconds. Very important. Patient keeps looking down for 15 to 20 seconds. and then he looks at your nose. He makes an upward saccade. Looks down for 15 to 20 seconds, then he looks at your nose, makes an upward saccade, and what you find is the eyelid goes up and then slowly settles down. 3 minutes, 2 more videos. Diagnosis and lesion. Where the lesion will be. Patient is converging. This is how the eyelids look. And patient looks straight. And this is how the eye behaves when the patient is converging. So patient looks straight. The eyes are like this. What did you see? So patient looks straight. The eyes are by and large normal, though the patient has exotropia. But when patient converges, both the eyes actually go down. There is a narrowing of pupil fissure sort of thing. In other words, there is a retraction and also there is a nystagmus. So this is convergence, retraction, nystagmus. Localizing lesion to? This is a part of Perinote syndrome. The lesion localizes to dorsal midbrain. This is also called dorsal midbrain syndrome. Last video here. Patient looking straight. So nystagmus, where would you localize the lesion? I said 80% of the time, cerebellum. So this patient has nystagmus. Where would be the lesion? Cerebellum. This is an example of a gaze-evoked nystagmus. You will see a rotatory nystagmus. Important feature to look for in nystagmus is 1, whether it's gaze-evoked, and 2, whether it is vertical. And you will see here, when the patient looks down, it becomes a down-beating nystagmus. So with that, I think I'll end. Thank you so much.
Thank you, Rashmi. What an amazing talk, what an amazing teacher. A big round of applause for Rashmi. Very nice, very nice.
I just want to congratulate you. I think in my career, I have never attended a better post-graduate class than what I just saw. So I think it was one of the excellent presentations and I congratulate you.
Thank you, sir.
Anybody who missed this presentation missed the word. I would now like to invite Dr. Partha Mandal, who is our next speaker. He is from Durgapur, West Bengal. He has done his MBBS from Kolkata and he did his post-graduation also in Kolkata. He did his fellowship in L.V. Prasad Eye Institute and presently he is the Chief Medical Officer of Disha Eye Hospital, Durgapur, West Bengal. And he will be talking to us today on basics of automated perimetry and interpretation of visual fields. Dr. Partha Mandal.
Good morning, respected chairpersons. At the outset, I would like to thank the Scientific Committee of All India Ophthalmological Society for giving me this opportunity. I'm really afraid of the audience. I'm not a teacher here because the way you have answered Dr. Rashmi's question, I'm really afraid of you teaching this thing. But let's be interactive and I'll try to share my knowledge with you. I don't have any problem if you are taking any photographs of my slides. It's open to you, it's for you. But rather, if you concentrate on my slides, it will be very good for you. And at the end, I'll give my email ID. You can send me your queries, or if you want the whole presentations, I can send it to you. So it's yours. I don't have any problem. The matters I am just discussing, I don't have any financial interest to any particular machine, but definitely I'll be sticking on to the Humphrey field analyzer because of two reasons. One is mostly, or I can say the only machine I am conversant with this is the Humphrey visual field analyzer, and this is the literatures and the studies are mostly based on the Humphrey visual field analyzer. What we do with the perimetry, it is the important tool to assess the visual function outside the fovea. What it does, it measures the sensitivity at different points of the retina, and ultimately, finally, you will get some printout where there are measured sensitivities will be written in the decibel value. and the sensitivity is interpreted as the sensitivity of the decibel value or the stimulus intensity, where the patient is likely to respond at 50% of time. The perimetry itself needs a degree of psyche. At the same time, there should be some intact neural pathway from right away from retina to even the motor centers. So there are some prerequisites for doing the perimetric test. Better to have the visual acuity at least 20/200, and at the same time you need patient's cooperation without any sort of disability like Parkinsonism, neck stiffness, claustrophobia and arthritis. The reason I am asking, because before thinking or before ordering the perimetric test, you should think of all these things, whether the patient can cooperate or the patient's vision is such that the patient can do the visual field test. So by perimetry you can not only evaluate the optic nerve head, or for the glaucoma, the whole visual pathway you can evaluate by the perimetric test. So what are the diseases for which we do perimetry? One is the glaucoma, as you know, that's ganglion cell disease. For the glaucoma management and for the diagnosis, it is very much essential. It is often used for optic pathway lesions, including the optic nerve disorders. It is important tool sometimes in the management of retinal disorders, and sometimes to certify the visual function in rehabilitations or any program. What are the variations? In the conventionally, we use white on white perimetry. That's the white background. We put a stimulus of different contrast over the background. So we usually test the differential contrast sensitivity. That is our standard conventional. The others, non-conventionals, use like blue on yellow perimetry, or that is the SWAP shortwave automated perimetry, where against the bright yellow background we put a blue stimulus to find out the blue cone status. The others, sometimes some advocate a red on white background for studying the different, specifically the drug-induced maculopathy, and sometimes the functional test to find out the functional status of the patients. Just one point I want to highlight, in perimetry we usually get the notion decibel value. It have a wide range of decibel value from 0 to 50, but the decibel notion is to find out the sensitivity where the machine uses the stimulus intensity which is in the apostille. So the brighter, that is just the reverse, the brighter the stimulus the patient can perceive, the decibel value is the lower, or the dimmer stimulus can perceive the decibel value is higher. As you all know that the field of vision is usually said as the hill of vision. It is a hill of vision, and the perimetry or the perimeter determines the height in different areas, and at the same time the shape or the extent of the field of vision. So in that way you can get, this is the temporal extent, this is the nasal extent, and in the decibel each area the height is usually represented as the decibel value. Any departure from this hill of vision is usually depicted as field defect, like this is the departure of the hill of vision, but this is the physiological field defect, that is the blind spot. If you get a defect like this, the perimeter usually determines the area where the defect is and what is the height of that defect. Like in the inferotemporal area there is some defect, and this can be represented as a decibel value which is lesser than the surrounding values 19, and in the grayscale you can find out that this area sensitivity is less. So this is the thing the perimeter does. If there is any defect or any departure from the hill of the vision, that can identify the area as well as the size of the defect. Over the years, the methodology differs basically in two ways. One is the kinetic, the previously usually used the Goldman perimeter, and the static automated perimeter. In Goldman perimetry, the single intensity is moving from the non-sing to sing area. So if you move a intensity from this to this sing area, you will get an isopter. For each target or each stimulus, you will get an isopter like this in the whole field of vision. So the clinician just find out different tiers of this field of vision. But what we do in the automated perimeter or in the static perimetry, the variable intensity with a fixed target. The target is fixed, the target site is fixed. We change the stimulus intensity, and by that we usually get the individual area of sensitivity. So in perimetry, what we get? The area-wise representation of sensitivity. But with the method of automation, or with the help of the machine by the stat pack analysis, we want to find out whether this measured sensitivity is out of the normal range or within the normal range. How it is done? It is done by stat pack analysis by comparison with the normal. And it finds out whether that field defect or that defect is significant or not. This is the basis of choosing different machines. This is a commonly asked questions: which machine should I buy and which machine should I use? Whatever machine is used, what is the database, that depends, that usually indicates the machine is good or not. So that is your idea, that if the database is good, like a Humphrey field analyzer, it has a multi-center database and including even the Indian populations and sometimes the random sampling. So that is totally dependent on you, to which machine you will choose. But most of all the machines are based on the stat pack analysis in the similar way. So what the perimetry does is it does the field of vision area-wise representation, and with the stat pack analysis we get whether there is any defect, or if the defect is there, whether it is significant or not. As a clinician, you need to do just the correlation. So what is the need of getting all together into the machine as well as the field interpretation? So it is only the automated perimetry, and you can think of the case is already over by this. But there is some noises which produces some problem with us, because the patient may have unreliable field, the patient may have a field defect with the learning curve, or there are some simulating condition which may mimic like glaucoma or some retinal disease which may mimic in the same way. So what we need to know the methodology and at the same time interpretation. Quickly to do what is the method, the perimeter used, usually it measures the phobia threshold first. There is a different contrast sensitivities are used and different intensity stimulus is used, and when the patient proceeds, that we get as the phobia threshold, which is presented in just below the reliability parameters as a threshold value, and if it is abnormal there will be a shaded symbol. This I will talk later on about this. After the phobia threshold, the machine usually indicates the threshold value in 4 primary points in 4 quadrants, and after that it localizes the blind spot, and then the other points are tested. This is the standard protocol of the machine. How the other points are tested? Depending on the whatever the phobia threshold and at the same time the primary point threshold, it has got some extrapolation from which the sensitivity should be started. And from there, it uses the 4-2-2 algorithm. Just for your sake, I am telling, it usually increases the 4 decibel value until and unless it crosses the sensitivity area. When it crosses the sensitivity area for that particular area or for that particular patient, it again comes down by 2 and 2 till the sensitivity point is reached. So this is called 4 decibel higher, and then again goes back to 2 and 2. And this is usually in the standard full threshold test, and there are some other strategies. Regarding the strategy, I will talk to you later on. There are some other strategy which uses the different algorithm for the time management. The different formats are placed, and it is written here in as the single field analysis or the overview, where the results up to 16 tests are displayed in this way, so that there will be a easy interpretation that with time it is changing or not. The other is change analysis. It compares up to 16 tests and it analyzes the indices of changes, whatever the changes from the baseline that it indicates in this way, that the box plot way. And lastly, the glaucoma change probability analysis. The Humphrey machine itself has some stable glaucoma patients database, and depending on that database, it indicates whether the changes in the subjects you are tested, which is significant or which is different from the stable glaucoma patients. That is the change probability analysis printout. The types of tests you should know, there are 2 different types of tests. One is the thresholding and one is the screening. In the threshold, it is a precise quantification of that particular area and what is the sensitivity. But screening, what it does, it indicates that whether there is a generalized defect or any localized defect. In screening, what it does, the machine extrapolates a certain amount of decibel value for each area, and the machine presented 6 decibel height to that area. If you respond, if the subject responds, then it indicates as the point seen, and if it does not respond, it indicates the point is not seen. So, in screening test, sometimes it's useful definitely just to find out the existence and the location, and at the same time the pattern of the field defect if the patient has anything. The different areas, it is written here at the central or peripheral, and the areas are maybe 24-2, 30-2, 10-2. You have heard about this. Just to find out that this is the Goldman visual overlay, visual field overlay, just to find out the ganglion cell distribution from the center of the fovea to the outside. Each enclosed area is the 1%. You can find out the centers are more concentrated. Just to find out 5 degree, within the 5 degree there are 12% ganglion cells, within 10 degree 34%, and within 30 degree 70%. In the glaucomatous field, very rarely we can find the defect only beyond 70% but not inside. So we are more concentrated on central 30-2 or central 30 degree. This is the central 30-2 program where there is 76 points are distributed in 30 degree area, and in 24-2 program where the points are distributed in the 24, including the 2 nasal in 30, which I will tell you later on. So the pattern or the area are different, either central or the peripheral. It may be 30-2, it may be 24-2, it may be 10-2. This is the 24-2 versus 30-2 program, which we usually always look after. The sometimes somebody are preferring 30-2, but we are preferring 24-2. Why? It is 54 points in 24-2. Basically, the time management. It decreases the overall time the subject needs to perform this perimetric test. Here there are 30-2, and in 24-2 the peripheral points are eliminated, but the 2 nasal points are there, because the nasal points are definitely important in glaucoma management, that I'll tell you later on. So just to recapitulate a little bit about what we know right now, what is threshold sensitivity, like the 50% time the patient is likely to respond for that. What are the prerequisites for doing perimetric test? What are the variations? Like the standard is white on white perimetry, others are like this. Types of perimetry are the threshold or screening test. The threshold is always preferable than the screening, but it takes more time. Sensitivity versus stimulus intensity, already I have discussed. The sequence of events. First, it indicates the foveal threshold, after that the 4 primary points, and depending on those foveal threshold and 4 primary points, the other points are detected. The printout format, either is the single field printout, the change probability analysis, the change analysis, or the overview. And the types of test, as I already told, the strategy or the threshold or the first pack strategy, something like that. Pattern, the area central or peripheral, whether the central 30, 24 or 10. Few more things you should know, what is the strategy. Like the strategy, specifically there are 2 types, one is the standard and over the first. This is basically just for the time management. In standard, 2 types, full threshold and Sita standard. In first pack strategy and the first pack in the full threshold first program, and Sita program is Sita first. Just to choose test, which one you should do. Like if you think of standard threshold perimetry in 30-2, it takes about 14 minutes per eye, whereas in 30-2 Sita standard